over the last couple of years, there's been several new drugs approved by, both the European agencies and the Drug Administration here in the United States. And we essentially have now two new drugs that target different signaling pathways, or two different inhibitor pathways that can be targeted by the different drugs that we have. So the first step is you decide whether the patient would be better served by using daily continuous use of one therapy. And so that would be a BTK inhibitor, a Bruton tyrosine kinase inhibitor, such as Ibrutinib or Acalabrutinib, which are both approved for frontline therapy, or using a fixed duration regimen, which would be a BCL2 inhibitor, which you use for 12 months or 12 cycles in combination with the monoclonal antibody Obinutuzumab. And this all came from trials where you compared it against the best chemoimmunotherapy regimens, right? So there were several trials that led to these approvals. Ibrutinib was tried and tested and presented in large intergroup studies. First, against FCR, Ibrutinib was given with rituximab for young, fit patients, and it was randomization of 2-to-1. Two patients received Ibrutinib with rituximab, or one patient received FCR. And so the data was presented at last year's ASH by Tai Changfeld, and it essentially showed how there was a better overall survival and better progression-free survival. So at last year, we presented the longer, more mature data. At 2018 ASH, we presented the initial data analysis that showed that even then, an early signal was that the patients actually had a better overall survival when they were randomized to Ibrutinib with rituximab. So even though they were very, very few events, it was statistically significant, and that was the reason why in the United States, we kind of embraced the use of a BTK inhibitor for frontline. Then last year, the data for Elevate-TN trial from Acalabrutinib against, against Obinutuzumab with chlorambucil or Acalabrutinib in combination with the monoclonal antibody Obinutuzumab showed that these patients randomized to the Acalabrutinib containing arm were doing so much better. 30-month PFS was, in the high 80s to 90%. So patients were much, more in remission when they were randomized to Acalabrutinib. So Acalabrutinib was approved sometime around November 2019 in the United States. You can either choose a BTK inhibitor to do continuous daily dosing. So the drug is used daily or twice daily, depending on which one you choose. And then you use it until tolerability issues or progression of disease. Now, the problem is that over time, you can have symptoms that initially they don't bother you because, of course, what you want is to get the disease in remission. But once you start getting some of the toxicities that can be associated or seen with these compounds, like, for example, atrial fibrillation, bleeding events, myalgias, hypertension, if you get that over time, after 2 years or 3 years on therapy, you are like, can I stop this drug, doctor? And so what happens on the counterpart is that at the same time that these BTK inhibitors were being developed, another group of scientists developed a BCL2 inhibitor, which now is called venetoclax. And so the BCL2 pathway targets the apoptotic pathway. And so what it does is that instead of targeting the B cell receptor signaling pathway mechanism, venetoclax, what it does is essentially tells the cells to remember how to die. And so that is one of the main potential toxicities if you don't follow the protocol strictly on how to give the drug, which is that you can actually have severe tumor lysis syndrome events. So you have to be very careful and conscientious on your patients and the risks that they have. So if they have a white blood cell count higher than 25,000, or lymph nodes that are bigger or lymph nodes that are bigger than 5 centimeters, for these high-risk patients, you should consider admission to the hospital for hydration and real-time monitoring. You give the drug 20 milligrams for 1 week, and then 50 milligrams, then 100 milligrams, and 200 milligrams to target dose level of 400 milligrams. Once you are at the 400 level, the side effect and toxicities are very minimal. For the majority of patients, what has been seen is neutropenia, but neutropenia is responsive to G-CSF use. And so what is enticing for the patients is that it's a fixed duration regimen that they only need to take for 12 months, and then 6 cycles of obinutuzumab in combination. The obinutuzumab is given for 1 month to debulk, bring the risk for serious TLS down, and then you add on the venetoclax, and then you continue for a total of 12 months. But the concern nowadays in certain areas with high COVID prevalence is that the potential that in a patient with high-risk disease, these patients would need to be admitted to the hospital. In an era where, for example, here in New York, we had a huge tsunami of events of COVID, it was not possible. And so we tried our best to do these dose escalations in the outpatient setting. And we were successful on a couple of cases, but it was very risky. As long as you acknowledge that you need to be on top of this laboratory testing, that is something not in the guidelines, but you do what you can to save, the life of your patient if your patient is otherwise unable to take a BTK inhibitor. In the case of one of my patients, she actually had spontaneous hemorrhagic bleeds in the CNS, in the brain, so she was not a candidate for a BTK inhibitor. So it's good to have options. The issue is, again, that, both ways to treat the patient have never been tested against each other. All of them were tested against the standard of care, which at the time was chemoimmunotherapy regimens. So treatment strategies where you say, well, this drug seems to be better than this other drug, unfortunately cannot be done because you cannot compare inter studies or inter trials, because the patients had different characteristics, and so it's hard to compare across different studies. Important to recognize are the patient's characteristics in the physical presentation of the patient. Are they fit or are they unfit? How easy is it for them to come to get the infusions for obinutuzumab if you choose to use a monoclonal antibody? You have to remember, for a BTK inhibitor, you can use it as monotherapy or in combination strategies with a monoclonal antibody, such as ibrutinib with rituximab, or ibrutinib with obinutuzumab, or acalabrutinib as monotherapy or in combination with obinutuzumab. The issue is that for a BTK inhibitor, we really don't know if the addition of a monoclonal antibody adds to anything. In the study led by Jennifer Voyage, the Alliance trial, ibrutinib was compared against BR in older patients, older than 65, or ibrutinib in combination with rituximab. And it was a very impressive curve of PFS, where the progression-free survival was much better in the ibrutinib-containing arms, but there was no difference between patients that received just ibrutinib or ibrutinib in combination with rituximab. So from our perspective, rituximab doesn't really add anything, and we don't recommend to add on the rituximab agent. Now, for acalabrutinib, when the trial ELEVATE-TN was presented, we saw that there seems to be an improvement in the progression-free survival, but it was not statistically significant, and the trial was not designed to do comparisons between monotherapy and combination treatment strategies. So we will never have the answer unless that trial is done. And both results are impressive, very high remission duration at 30 months. So we truly don't also advocate to add on a monoclonal antibody for patients treated with acalabrutinib. If you use a BTK inhibitor, most likely you will just get monotherapy. For patients treated with venetoclax, there's never been a study that does monotherapy against combination treatment strategies that has been presented. So this is another study where we would prefer to have some data available, but we don't have it. So the way that the combination regimen has been approved is in combination. And so we recommend that, off trial. Now, there are novel treatment strategies. When you have, these great agents, then why don't you combine and see what happens? And so Bill Weirda presented the results of the Captivate trial in frontline patients. We participated in that trial, and they combined Ibrutinib with venetoclax. Ibrutinib was given for 3 months frontline to debulk, to decrease the risk for TLS, and then you add on venetoclax in a fixed duration treatment strategy. And what you see in the combination is that there's no new signals. It's a very safe combination, and you can actually achieve undetectable MRD in several of the patients, which can correlate with time in remission duration. So we are all very excited about these things. Important to know for frontline selection of treatment strategies that you always have to check for deletion 17p, TP53 mutation by next generation sequencing, and unmutated or mutated IGHV state. You want to know that because there is a subgroup of patients which is limited to mutated IGHV, no 17p deletion, no 11q deletion, that could potentially be treated with chemoimmunotherapy regimens such as FCR or BR and achieve a very long remission duration. The only problem is that, again, you have the risk of serious myelosuppression or infection risk or possibility of later on secondary malignancy. So that is the reason why we in the United States are trying to move away from chemoimmunotherapy treatment strategies for frontline. Important to recognize also the patient's comorbidities. If you have a patient with severe bleeding history or bleeding diathesis or recent surgery, you might want to stay away from a Bruton tyrosine kinase inhibitor. And if you have renal insufficiency, for example, you might want to stay away from venetoclax. The other important thing that I mentioned is, in the era of 2020, when we're trying to get access to all our patients, is that some of these drugs are so expensive that unfortunately some of our patients will have to be treated with chemotherapy. And that's why we talk about all these potential options, because the availability of the drugs may not be there, not only in the United States, but also in other countries where these drugs are just out of the reach of the majority of the population.